I am very pleased to have you as guests in this webinar that has been organized by ESSO, and in particular, it has been organized by the Education and Training Committee that is divided in subgroups. And the subgroup that deals with upper GI malignancy is very proudly composed by young people. This is a message from young to young. And what is extremely important in these days of continuous and profound news regarding the best multidisciplinary approach to upper GI cancer is being informed about what is going on all over the world in trials that are totally committed towards esophageal and gastric cancer. We have 3 speakers today. All of them are brilliant young surgeon researchers and oncologists, and they will deal with what is the update for trials in this field in Europe, in the US, and in Asia. The first speaker is Dr. Florian Gebauer. He graduated in Hamburg, and he is a senior researcher now in pancreatic cancer in upper GI. He's the principal investigator for the Olimark study, and I am very happy to have him today with us, speaking about update in upper GI trials in Europe. Please, Florian, the mic is yours.
Domenico, thank you very much, and the organizers of the ESSO, Yogesh as well, for give you an update on the trials ongoing in Europe. So I'm the head of the clinical research program in Cologne in Germany, and as you might know, we are pretty busy on upper GI, especially in esophageal cancer surgery. So in my talk, I would like to focus a little bit more on esophageal cancer than on gastric cancer. On one hand, this is my special topic, esophageal cancer, but on the other hand, in Europe, we have a pretty large community for studies on esophageal cancer, but not so much on gastric cancer, and this is to focus a little bit more on this. So what I would like you to present some really interesting studies on concepts, especially on chemoradiation and chemotherapy. The large question of what to do with patients after a complete response after neoadjuvant therapy. There are 3-4 ongoing studies on this topic. Lymph node mapping, a very interesting topic. The Tiger trial would like to show you from the Dutch group. And then I would put the focus on surgical developments. This is the surgical community here, community. So I think this is an interesting topic. So to start with the neoadjuvant therapy. Today for esophageal cancer, I think this is common sense. For locally advanced tumors, that means T3 or 4 tumors, all lymph node positive tumors, any kind of neoadjuvant therapy has been established within the last years. So the question is whether to administer the neoadjuvant chemoradiation therapy, commonly used as the CROSS protocol from the Dutch CROSS group, or the neoadjuvant therapy according to the FLOT protocol. You all know this data from the CROSS group, first published about 10 years ago, and just recently the 10-year follow-up that showed a beneficial outcome for patients on esophageal cancer after neoadjuvant chemoradiation therapy. The effects were a little bit more clear for the squamous cell carcinoma than on adenocarcinoma, but I think this was a groundbreaking study that showed for the first time the clear effect of the neoadjuvant chemoradiation therapy. So up to date, this is the standard protocol whenever you do a chemoradiation preoperatively in esophageal cancer. chemotherapy alone was a mixture after the MAGIC trials for upper GI cancer, gastric cancer, and GE junction cancers. And a few years ago, from the German groups from Albatran, he showed that the FLOT regimen is less toxic and a little bit more effective than the ECF or ECX scheme that was used in the MAGIC trial. So today, the FLOT scheme is for chemotherapy alone the standard. And also the outcome was better for FLOT than ECF. So the question but today is whether to apply a chemoradiation therapy upfront surgery or a chemotherapy alone. And there are two ongoing trials that address this topic in Europe. The ESSO trial is conducted throughout Germany, and it specifically addresses this topic. They are only included esophageal cancers. About 440 patients have to be randomized 1-to-1, either to the FLOT chemotherapy perioperatively. You can see it here on the left arm side. So FLOT, surgery FLOT, or in the chemoradiation arm, cross and surgery. The primary outcome is the overall survival. Recruitment has been completed a few months ago, and we expect the first results end of this year. That would be really interesting. So another trial addressing this aspect as well is the neo-AGAS trial. Last year presented on the ESSO from John Reynolds. And they conducted very similar, so a perioperatively chemotherapy compared to the cross protocol. The problem on this study is, in my opinion, that there was a mixture of perioperative chemotherapy applied. They started recruitment with the ECF, ECX scheme, and then changed during the study to the FLOT scheme as the FLOT results were published. So these are preliminary results presented last year, as I said, and they showed no survival difference between cross and this chemotherapy arm. So I think this topic has not been discussed, but in this study, we did not see any difference. What would be interesting is the NEORES-2 trial from the Swedish group. So from the Karolinska Institute in Stockholm, they put the focus on when to operate a patient after the chemoradiation therapy. So today on the CROSS trial, they reported an interval between completion of the chemoradiation and the surgery about 6 to 8 months. But this is the only data we have. It was not aim of the study to address this in particular. So the NEORES-2 trial compares an early surgery after chemoradiation, 4 to 6 weeks, and a late operation, 10 to 12 weeks. The primary outcome is the pathologic complete response, and the secondary outcome, and I think, in my opinion, this is the more important for the patient, the overall survival, if there is any difference. Study is completely recruited, and we expect the first results within the next weeks or months. So I think this is very interesting when to operate the patient. To come to gastric cancer, we have an interesting study here in Germany started a few weeks ago. This is the FLOT9 trial, or the PREVENT study. And this is locally advanced gastric cancer. And that compares the study, the standard FLOT perioperative chemotherapy compared to HIPEC en principe in locally advanced, not metastasized tumors. So I think this is an interesting study. I think we can discuss alone on this study about 1 hour maybe. The patient to have to be randomized 1-to-1, it's 200 in total. I think this is an enormous number of patients. The primary endpoint is the progression-free time. Secondary endpoints, as you can see here, overall survival, morbidity, and so on. I think this would be interesting if the recruitment is feasible in this study. I don't know yet, to be honest. I come to the next aspect, the clinical complete response. Always a big question. You do a preoperative therapy, either chemotherapy, chemoradiation therapy. You do an endoscopy, CT scan, and you see the tumor has vanished and it's not detectable anymore. And then the question is what to do. Up to now, the standard therapy is the operation on principle after some kind of neoadjuvant therapy, but there are several studies that are addressing this aspect. So all the studies I would like to present you now have in common that there is a surveillance arm, a little bit comparable to the rectal cancer studies that are ongoing now after the implementation of the total neoadjuvant therapy in rectal cancer, and the intervention arm with the surgery. These are the studies here, the ZANO trial from the Netherlands group. I think this is the most important and most famous trial. The recruitment has been finished, but we haven't seen the results yet. The ESSO trial from the France group has terminated the recruitment. I don't know why. It's not published why they terminated the study. The ESSO trial from Germany, from Lübeck, will start within the next months recruiting the patients. And the ZANO 2 trial is an extension of the ZANO trial. There is a protocol already published, but as far as I know, the recruitment has not been started. It just started a few weeks ago. So the ZANO trial was pretty easy in its concept. I think it's the advantage of the study. So patients after neoadjuvant therapy that showed a clinical complete response underwent under a active survey or a clinical response program. And you can see it here. They had to confirm the complete clinical response at least 2 times and were then randomized either in the standard surgery arm or in the active surveillance arm. And then it goes the horizontal line, the CRE, the clinical response evaluation after every 3 to 4 months then. The ESSO trial from Germany is a little bit different, and I apologize, I have only found this flow chart in German, but I think the key points are to understand even and if you don't speak German. So all patients, irrespective of squamous cell or adenocarcinoma on any kind of neoadjuvant therapy can be included, and they are randomized irrespective of the clinical response evaluation. If they have active tumor detectable in the endoscopy or CT scan, then they go directly to the operation. If they are randomized in the study arm, then they are on the light green arm there. Then they go to the clinical response evaluation. If they have tumor left, then they were operated. If they have not, then they go to the clinical response evaluation. So it's a little bit different in detail to the ZANO trial. It will be interesting. So they mix chemoradiation and chemotherapy and squamous cell and adenocarcinoma. It's a huge study. They want to answer, I think, everything in this trial. It would be interesting if this works and what comes out there in the end. Another trial from the Swedish group in Stockholm, the NEEDS trial, it's a real global trial. So the NEEDS trial addresses only squamous cell carcinoma. And they randomized the neoadjuvant therapy after cross therapy and then the operation compared to the definitive chemoradiation therapy and the surveillance and the surgery on demand after that. So patients have to be randomized, as you can see here, 1,200. It's a large number. Primary endpoint is the overall survival. What you can see here, it's a global study, as I said, from the US to Europe, Far East, and Australia. Numerous centers are involved in this trial, and would be very interesting if the definitive radiochemotherapy is a real alternative to the chemoradiation surgery pathway in squamous cell carcinoma. So let's talk about surgical developments in upper GI surgery. So a TIGER trial from the Amsterdam University. I think this is one of the most important trials within the last years. So today, we report the number of positive lymph nodes and the ratio of number to resected lymph nodes. But what we do not know exactly is the lymph node metastasis pathways in esophageal cancer and GE junction tumors in detail. So the TIGER trial addresses this aspect, and they do a very detailed lymph node mapping. It's not an intervention study in itself, but patients that are included have to follow very strict histopathological protocols. All the color code you see here on the maps have to be addressed by the pathologist. So in the end, we have hopefully a complete overview which tumor on which localization metastasized to which localization on the lymph nodes. So I think this is interesting because today we do not know this on detail. It's again a global study. You see here the recruiters so far. It's a huge number of patients to have to in total about 5,000. But I think it's interesting in the end, and it will widen our view on cancer metastasis. A study we're conducting in Cologne is another. It's the CARDIA trial. You might know that how to operate a type 2 tumor on the GE junction is ongoing. Some centers do the esophagectomy, transthoracal. Other centers perform an extended gastrectomy. So today there's no clear answer which type of operation is beneficial for the patient. And we started this trial a year and a half ago, and we randomized 1-to-1 either Lewis esophagectomy or the extended gastrectomy. The patients we need is 260 in total. We have as our sidekick in the Netherlands, the University of Utrecht, recruits patients in the Netherlands as well. And the primary endpoint is survival, and you see secondary endpoints are morbidity and the quality of life. The first results I can show you here, it's no secret, we included about 40 patients. The average hospital stay is 4 days. Open surgery, these are mainly the gastrectomies, is about 50. The extent of lymph node dissection is in median 55, I think it's a lot. But we do not have any oncological outcome data so far. Maybe next year we have some preliminary results. Another trial that addresses gastric cancers, the MEGA trial from the Heidelberg group in Germany. They compare in a very simple, but that means it's not simple, means laparoscopic compared to open surgery in gastrectomy. They want to randomize 160 patients 1-to-1, and the primary outcome here in the MEGA trial is the overall survival. Recruitment started already a few weeks ago, but we haven't heard of any results yet. So some developments on esophageal cancer and some interesting studies that are there ongoing. This is some kind of a historical development from the open Mekion operation in esophageal cancer up to state-of-the-art robotic assistant, total minimal invasive, either Lewis or Mekion surgery. So there are numerous studies comparing each of those therapy concepts. It first started with the comparison between the open and the minimal invasive Mekion surgery. Then I think, very famous Miro trial from the France group that compares the open to the hybrid Ivolus esophagectomy that showed a clear benefit for the hybrid esophagectomy. Hybrid means the abdominal part is minimal invasive and the transthoracic esophagectomy is by open surgery. It went on then to the total minimal invasive approach with the robot-assisted trials and so on. And then in the last years, it focused more and more between total classic minimal invasive surgery approaches to the robot-assisted approaches. There are some studies ongoing. The Romero trial from the UK that compares open esophagectomy compared to hybrid or total minimal invasive. The primary outcome is the quality of life here, but we haven't heard any results yet. The Robot 2 trial is from Mainz that compares the robot-assisted and the minimal invasive surgery. And the Mickey trial that compares the best of all of three of them, hybrid minimal invasive surgery compared to the total minimal invasive in the robot transthoracic esophagectomy. So I will finish. There are some things I didn't show you. I didn't talk about immune checkpoint concepts here. So there are numerous studies, even in Europe, that addresses this aspect. But I think this is mainly the field in the adjuvant or in the palliative setting of in the field of the medical oncologist. I didn't talk about targeted therapy in gastric cancer, for example, HER2, and any kind of biomarker studies that may have to stratify patient. I think this is too much for 20 minutes talk here. I think what will be talked about in the future, the studies comparing chemoradiation, chemotherapy, I think new EGIS and the ESSO trials are very, very important for the future to have a better decision-making, what patients receive, what kind of neoadjuvant therapy. New REST-2 trial, I think it's important because we do not exactly know when to operate a patient after chemoradiation therapy. And the Tiger trial is, from the scientific point of view, interesting to see which patient metastasize in which way. So I thank you very much for your attention. This is the Cologne Cathedral, very, very famous in Cologne. And I'm happy to take your questions. Thank you very much.
Thank you, Florian. That was an excellent overview, and we appreciate especially your last slide when you have expressed the fact that there are so many other studies that are going towards other direction that somehow are not entirely in the focus of our webinar tonight. I don't know if we would like to have a question time after the three presentations, since some of the different studies are overlapping through continents, and we have a couple of technical chairmen. One is Dr. Yogesh Vasist from ASAC and the ETC group dealing with upper GI, and the other one is Jan-Willem Vandenberg. They will be commenting at the end, selecting your questions. You are cordially invited to submit your questions that will be addressed to the speakers at the end of the three presentations. So the next speaker now is a guest of ESSO, is Jonathan Cools. Jonathan is a young lead researcher at the Research Institute at McGill University Health Center in Montreal, Canada, in Quebec, and he's assistant professor of surgery at McGill. He's an attending surgeon at Montreal General Hospital, and he works in the division of thoracic surgery. Jonathan, please, the microphone is yours.
Thank you very much for that kind introduction, and thank you for the opportunity to speak today. Let me just start my slides here. Can everybody see my slides? Just making sure.
Yes,
Excellent.
yes, okay.
Okay, great. So I'll be given basically an update on trials taking place with respect to upper GI malignancies, focusing predominantly on esophageal and esophagogastric junction cancers. I'll be going over predominantly the North American studies. So I'll just start briefly here to say, this is a big problem in both North America and much of Western Europe. Just on the right and the left, these are incidence and mortality slides for esophageal cancer. And because esophageal adenocarcinoma is increasing both in prevalence in both of those continents, I'll be focusing much of my talk on that. So currently, the treatment of esophageal adenocarcinoma at our institution is based on a perioperative chemotherapy regimen, FLOT, and centers on en bloc transthoracic esophagectomy, which we do minimally invasive and hybrid predominantly, not so much robotic. The main problem, while we were able to get very good results in the early phase with respect to local regional tumor control, most of the failures are distant. And so the question is, what about therapy? So I'll just go briefly through, the CROSS trial and the FLOT trial, which established these neoadjuvant or perioperative regimens as standards of care for the management of esophageal cancer in improving overall survival and preventing recurrence. But I just want to point out that, when these studies came out, there were clear differences, particularly in the CROSS trial with respect to adenocarcinoma and squamous cell carcinoma, with respect to their response rates to the given therapies. And this has sort of formed a debate over time about, which regimen is best and which one should we use. And I'll just move forward since this was presented briefly, which one should we use? And the answer is, I think that it's starting to become a little less relevant as we move into the era of checkpoint blockade. And for the remainder of my talk, I'll really be focusing on novel immunotherapies and targeted agents, which I think have revolutionized the systemic management, and I think will change the surgical management of esophageal cancer moving forward, particularly adenocarcinoma in North America. The first trial I want to start with, and we'll start in the metastatic setting. This is the Keynote 590 trial. It was really an international trial. It's kind of not fair for me to include it in the North American group, but there were a lot of North Americans on it. And I think it's an excellent trial to sort of lay the groundwork with respect to what's been done with institution of immunochemotherapy in patients with metastatic esophageal cancer. This was a mixed histology trial. It was a non-curable, locally advanced or metastatic esophageal cancer, meaning squamous or esophageal adenocarcinoma, and patients were treated with cisplatin 5-FU according to the oncologist's preferences, or cisplatin 5-FU plus pembrolizumab. This is just the study schema, but basically it's a large number of patients, 370 roughly assigned to each group. And they all received the therapy, sort of an intention to treat protocol. I just want to show this slide here. So 75% of the patients that were in it were esophageal squamous cell carcinoma. And this is the first trial that I think really brought to the fore this concept of the combined PD-L1 score, the CPS score. So historically, when people have looked at PD-L1 expression, they've looked at tumor cell PD-L1 expression. I think we know, whether it be from the esophageal cancer literature or the lung cancer literature, that PD-L1 expression within tumor cells doesn't always correlate with response to therapy. In fact, a better marker or better indicator of whether patients will respond is this combined PD-L1 score, which takes into account both tumor cell PD-L1 expression and PD-L1 expression on inflammatory or immune cell infiltrates. It's important to note here that about 38% of the esophageal squamous cell cancer patients had an elevated CPS, more than 10. About 25% of the patients were adenos, and only 12% of them had a CPS more than 10. And if you look at the forest plot here, the patients that seemed to derive the most benefit were those with an elevated combined PD-L1 score. And you see, as a result, I believe the squamous cell cancers seem to derive maybe a little bit more benefit than the adenocarcinomas. But it's important to note that, so these are the survival curves for essentially post hoc assessment of all these patients. So again, the patients that seem to derive the greatest benefit, okay, with a hazard ratio of 0.6, were the squames with a CPS more than 10. But that benefit was maintained with a low CPS, although more modest. If you include the adenos, that remains significant. If you look at all randomized patients, there was a significant trend towards improved survival, be it relatively modest, but certainly significant. However, if you include all patients, including the adenocarcinomas, with a low CPS, that advantage sort of disappeared. If we take this forward to the North American trial, the Checkmate 649 trial. This is a similar design. These were untreated, unresectable, HER2 negative cancers, and that's important. I'll get back to that a little bit later. And essentially, patients were treated with Zelox or FOLFOX until failure, and they were given either nivolumab or placebo. So a large number of patients were randomized, and a large number of patients were included in the analysis, over 700 in each group. These are just the patient characteristics. Here they give you tumor-derived PD-L1 scores, but it's just to point out that if essentially patients were comparable, they're all adenocarcinomas, included a significant amount of gastroesophageal junction cancers, and they also assessed for microsatellite instability. And again, most of the tumors were microsatellite stable, which recently has come to the fore with respect to efficacy of immunotherapy. If we look at the survival curves, again, there's that association with an elevated combined PDL score. This time they used more than 5 and more than 1. Both were significant with respect favoring immunochemotherapy versus chemotherapy alone, with a 12-month survival of 57% in one group and 46% in the chemo alone group. That's with a CPS more than 5. So the result is modest, but significant. And it's really one of the first significant trials to come out in this space in approximately 10 years since the publication of Cross and more recently Flott. The same was true with a CPS less than 1. And in fact, if you include all randomized patients, that there was a benefit. This was true for overall survival as well. The results were significant, albeit modest. So the next question that comes to mind is, well, can we exit the metastatic sphere? Can we help prevent recurrence in those patients that are able to undergo standard of care curative intent therapy? So this is the Checkmate 577 trial published in the New England Journal of Medicine a couple of years ago. It's a fascinating trial. Essentially, patients were randomized in a 2-to-1 fashion to receive either nivolumab or placebo after chemoradiation and surgery for resectable, locally advanced esophageal cancers. Again, it was a mixed histology trial. Therapy was instituted about 4 to 6 weeks after completion of chemoradiotherapy, and it was continued until recurrence or toxicity. The primary endpoint was disease-free survival, and the secondary was overall survival. I just show here that, again, it's a mixed histology study, which included a significant proportion of node-positive patients and a significant proportion of PD-L1 expressing patients. They did not use a CPS score, they just used a tumor cell PD-L1 expression. And in fact, it was quite a significant trial in favor of addition of nivolumab in the adjuvant setting. This was significant for both adenocarcinoma and squamous cell carcinoma. So again, maybe erasing some of that difference that we've seen historically with perioperative regimens, essentially comparing Cross and Flott. And I think even more interesting is if you just look at the time or the disease-free survival or time to development of distant disease, the adjuvant nivolumab arm demonstrated a significant improvement in their survival or time to development of distant metastasis. And this is essentially what we really need to prevent because this is where our patients fail. And so I think this is a very encouraging trial using a single agent in the adjuvant setting. Again, both esophageal cancer predominantly benefited. There was less of a benefit with respect to GEJ cancers. And again, you see a greater benefit with higher PD-L1 scores. Now, what about the neoadjuvant setting? So, I was just recently at ASCO this year, and that's essentially what everybody's talking about. Everyone is running some sort of perioperative trial with the institution of an immune checkpoint inhibitor to see if we can improve pathologic complete response rates as a surrogate for overall survival in the future. This is just a brief phase 2. This is the CALGB 8083 or Alliance trial. It's a trial out of the US again. This is a very complicated flow chart, but basically patients were randomly assigned to receive induction chemotherapy prior to institution of chemoradiation therapy for the management of their cancer. They are randomized to receive either FOLFOX or cisplatin paclitaxel. And what was shown is that those patients who demonstrated a PET response, meaning a 35% reduction in the SUV max while on induction therapy, had an advantage with respect to their pathologic response rates. So just for example, those patients that were started on FOLFOX and continued on FOLFOX and were PET responders had a PCR rate of approximately 30%, compared to those patients that did not demonstrate a significant SUV max drop. And FOLFOX was superior to cisplatin paclitaxel in the induction setting. So this sort of set the, and in terms of survival, there was no real benefit, but certainly in your pathologic response rates, induction chemotherapy guided by your PET response rates seemed to be efficacious in predicting at least pathologic response. Now, the question that arises is this valid in the era of induction immunotherapy? So, can we rely on PET scan to tailor our therapy if we're using immunotherapy in this field, considering that there are certain phenomena that we see with patients on checkpoint blockade, things like pseudoprogression and increase in tumor size, despite excellent pathologic responses. And for that, I'll just present an abstract out of Memorial Sloan Kettering, which was published this year by Jeffrey Kuh's group. He's a radiation oncologist in New York. And essentially, patients underwent a PET at diagnosis and then got 4 weeks of FOLFOX, where they underwent another PET response. Those patients that were PET responders were given durvalumab, followed by chemorads, followed by surgery. And then they got post-op durvalumab. Those patients that were non-responders also got durvalumab. And then the same thing was done. Those patients who had a major pathologic response, meaning 90% or less than 10% residual cells and N0, it's interesting because their genetic makeup changed. And this is an important concept because it comes up time and again in different trials, but they were enriched in aberrations with respect to HER2, MYC, PIK3C, and CDK N2A. Similarly, those patients with a higher tumor mutational burden, more than 15 per megabase, were more likely to respond. What's interesting is that their PET response was not predictive with respect to SUV max of their response. In fact, this particular patient who achieved a pathologic complete response after surgery had less than a 35% reduction in his SUV max, leading them to look at other metrics of response, including things like metabolically active tumor volume and total lesion glycolysis. Overall, their study showed a pathologic complete response rate of about 24% in all adenocarcinoma patients. A major pathologic response, meaning less than 10% viable cells, and N0, about 67%, and a YP-N0 in about 75%. But it's important to know that there was really no association with PET response and SUV max, and major pathologic response was very significantly associated with a CPS more than 5. Survival outcomes weren't significant, but it hasn't been very long. So the results are promising at this time. This is the result of a local trial at McGill at our institution, where we're using a modified DCF regimen, perioperative DCF, plus avelumab for checkpoint blockade. Patients are given 4 cycles of DCF, so docetaxel cisplatin 5-FU, plus avelumab, at which time they undergo surgery without radiation and then are given their postoperative 4 cycles. And the primary outcome was to see if we could achieve a 20% PCR and near PCR rate. We were able to do it. Our 0 resection rates were 100%. The PCR and near PCR rate was approximately 21%, with 7% having complete PCR and 14% having a near PCR. And again, as with the first study, PET response didn't predict response at the pathologic level. So, I'm not sure if that question is settled, but moving forward, certainly our reliance on PET is certainly going to change in dictating our management. The Matterhorn trial is recruiting now. This is a really exciting trial, essentially comparing FLOT plus checkpoint blockade versus FLOT alone. It's a truly worldwide effort, which is currently recruiting patients, and I look forward to seeing the results. Now, just to finish, I just want to touch on this briefly for the sake of time. What about targeted agents? There's been a lot of, hype since the TOGA trial, which is not a North American trial, showing a benefit with the addition of trastuzumab to HER2 positive gastric or gastroesophageal cancer patients. The results were significant, giving a modest benefit, although a statistically significant benefit, to patients who were HER2 positive and treated with trastuzumab. They tried, in the North American context, this was essentially, they tried to replicate this in the neoadjuvant setting in patients treated with trimodality therapy for HER2 positive adenocarcinomas. And in fact, this was a negative trial. There was no improvement in PCR, progression-free survival, or overall survival, leading the authors to really question the results. Now, I just want to point out they were quite rigorous in assessing HER2 expression in the primary tumors. They looked at both FISH and IHC. And when patients were very positive for both, they were counted as positive and then treated with HER2. So the question is, why didn't this work? And just to finish, I'd like to show you a trial I find truly fascinating out of Chicago by Daniel Catenacci called the Pangea trial. So personalized antibodies for gastroesophageal adenocarcinoma. It was a type 2 clinical expansion design, essentially like a basket trial, and it had a 1-year endpoint of your 1-year overall survival. Essentially 68 patients were evaluable, and the way the trial was structured, here I'll show you the schema here, is that patients were given chemotherapy with FOLFOX as first line and a biologic based on the results of their next generation sequencing. They were essentially stratified into groups based on that. So those patients that were immune checkpoint eligible, so MSI high or high CPS, patients with HER2 amplifications, EGFR amplifications, FGFR and MAC kinase, as well as MET amplifications. And these patients were compared to historical controls or patients in the group that were not able to get their biologic and were counted as a non-intention to treat group. Patients were treated until first progression, at which time they were rebiopsied, and they were retreated with a second-line agent plus a biologic, meaning that the biologic you get could change over the course of your treatment based on the results of a biopsy. So it's a biopsy-driven scheme. And in fact, it was quite significant. Overall survival, and these are metastatic non-resectable patients, approximately 16 months in the Pangea group and only 9 months in the non-Pangea group. Time to treatment failure was significantly improved. Overall survival was significantly improved. And it was most pronounced in the HER2 positive group. And I'll touch on that in 1 second. Same thing for in the modified intention to treat group, they were able to get some off-label use of other biologics. So basically, if you could give patients the appropriate biologic with chemo, they seem to do better. And the same was true in the various groups included in the study, depending on what your genetic aberration was. So their 1-year survival rate, was 66%, which is pretty excellent compared to historical controls, almost double. And 2-year survival was a third in metastatic patients with a median survival about 16 months. Progression-free survival was about 8 months in the treated group, 6.7. So no real difference, but their survival was longer if they were given the appropriate biologic. And as I said, the HER2 group did best. And just want to point out what the authors state, and I'll finish with this because I think it's truly fascinating moving forward, is that those patients that were treated with a biologic and then progressed had changes in their genetic expression patterns, suggesting that there was a evolutionary pressure on the tumor cells to change for those cells to get their biologic as a result of interactions with biologic. So what that means is just because your primary tumor may have been HER2 positive doesn't mean your site of first progression or your lymph nodes are. And in fact, it changed quite frequently in this particular study, suggesting that you need to confirm that your tumor is expressing what you think it's expressing at the site you want it to express it. And patients we know die of distant disease. So it's extremely important to make sure that their distant disease is genetically similar or different to the primary tumor. And with that being said, I'll finish. I think that was a pretty dense overview of what I think is happening in North America. And I'd like to thank you all for your attention and take any questions.
Thank you, Jonathan. That was great. And it is so important to observe that this webinar, these expert webinars, are an incredible tool in order to diffuse and share this kind of technical information to the largest audience. We have reached almost 150 participants, and we have people from very far countries, from India, from Georgia, from Iraq. And I'm really thankful for this participation, and I expect questions for you that should be sent through the question line on the chat box, and they will be collected and sent to the speakers by our technical chairman moderators, Yogesh Fascist and Jan Willem van den Berg. So now it's time to listen to the third presentation, the update from Asia. Unfortunately, due to time zone differences, this presentation was pre-recorded, but it's a very important speaker. He is Professor Do-Young Park. He has a strong interest in minimally invasive function preserving surgery in early gastric cancer, but he also is actively performing gastric cancer surgeries on, laparoscopic platform and robotic and single port gastrectomies. You know that the enormous amount of cases they have in Korea make Korean researchers always at the top, at the front line. He's a professor at Seoul National University College of Medicine in Seoul, Korea, in the division of gastrointestinal surgery.
Good evening, everyone. It's my great pleasure to be invited to ESSO webinar and to talk about upper GI malignancy trial updates from east to west. Ongoing trials in Asia. My contents include introduction of gastric cancer difference between East and West, surgical oncology trials in Asia, medical oncology trials in Asia. I think gastric cancer in the East has a higher incidence, earlier stage, lower BMI, higher volume center than gastric cancer in the West. As you can see, the incidence of gastric cancer is high in Asia, especially East Asia. The rate of oral gastric cancer is more than 60% in Korea and Japan due to screening gastroscopy. According to the global surveillance of trends in cancer survival published in the Lancet 2018, the highest level of 5-year survival was seen in South Korea for cancers of the stomach, 68.9%. It might be because the rate of oral gastric cancer is high, the BMI is low, and there are many high volume centers which are specialized in gastric cancer in Korea. Next, I'd like to introduce the surgical oncology trials in Asia. In Kinka Week 2018, which means Korean International Gastric Cancer Congress, a milestone was displayed with many surgical clinical trials in Korea, such as CLASS, Regatta, Expert, Senorita, etc. Among them, CLASS, Korean Laparoscope GI Surgery Study Group, trials are important and very active in Korea. Class 01 is RCT comparing LADG versus ODG for early gastric cancer. It proves the non-inferiority of LADG compared to ODG in terms of 5-year overall survival. The data were published in JAMA Oncology in 2019. Class 02 is RCT comparing LADG versus ODG for advanced gastric cancer. It also proved that the non-inferiority of LADG compared with ODG in terms of 3-year disease-free survival. The data were published in JCO in 2021. Class 03 is a phase 2 trial evaluating the feasibility of LATG for early gastric cancer. The study showed LATG was safe and feasible and was published in Annals of Surgery last year. Class 04 and Class 05 will be introduced later in more details. Class 06 is RCT comparing LATG versus open TG for advanced gastric cancer. The primary endpoint is 3-year disease-free survival, and the study is actively recruiting the patients. Class 07 is RCT comparing LADG versus TLDG. The primary endpoint is morbidity rate. It is also ongoing. Class 04 and Class 05 are randomized controlled trial about function-preserving surgeries. Class 04 trial is RCT comparing laparoscopic preserving gastrectomy with conventional distal gastrectomy. Primary endpoint is dumping syndrome. Last year, short-term outcomes of Class 04 were published in British Journal of Surgery. The overall morbidity rates of LPPG and LDG were 17.8% and 16.5% respectively. No difference. However, pyloric stenosis rate was high in LPPG group. Long-term outcomes were presented in International Gastric Cancer Congress this year. Next, Class 05 trial is RCT comparing laparoscopic proximal gastrectomy with double track reconstruction versus laparoscopic total gastrectomy for upper third oral gastric cancer. The primary endpoint is hemoglobin change and vitamin B12 supplemental quantity at postoperative 2 years. A total of 138 patients were randomized to LPG and LTG. The morbidity rate of LPG and LTG were 23.5% and 17.4% respectively. No significant difference. There was no mortality in both groups. These short-term outcomes were published this year in Journal of Gastric Cancer. These are the final outcomes of our primary endpoint. The hemoglobin changes after LPG and LTG were not different, even though there was a tendency of less hemoglobin change in LPG group than in LTG. Regarding vitamin B12 supplement quantity, the cumulative amount of vitamin B12 supplement was significantly less in LPG than in LTG. We checked gastric emptying scan to evaluate how much percentage of food passes through the remnant stomach. It reveals that about 60% of food passes through the remnant stomach, and the other 40% of food goes into the jejunum. The summary and conclusion of Class 05 were presented in IGCC this year as a plenary oral session. The conclusion was that among patients with upper third oral gastric cancer, laparoscopic proximal gastrectomy with double track reconstruction had less supplement of vitamin B12 than laparoscopic total gastrectomy, without compromising complication rate and survival. I'd like to introduce other class studies. Class 08 is RCT comparing LDG and ODG after neoadjuvant chemotherapy. The primary endpoint is the number of harvested lymph nodes. Class 09 is RCT comparing long-limb Roux LDG and conventional LDG for early gastric cancer patients with diabetes. The primary endpoint is rate of DM remission and improvement. Class 10 is RCT comparing laparoscopic partial versus total lumpectomy for advanced gastric cancer. Class 11 is cohort study about registry of esophagogastric junction cancer. Lastly, Class 12 is RCT comparing reduced port LDG versus conventional LDG. The primary endpoint was morbidity. Another function preserving procedure is sentinel node navigation surgery, but this is still investigational, not general practice. Dr. Geun-won Ryu, Korean National Cancer Center, conducted RCT comparing laparoscopic stomach preserving surgery with the sentinel Bayesian dissection versus standard gastrectomy with lymphadenectomy in early gastric cancer. This Senorita trial showed that 3-year overall survival of sentinel node navigation surgery was comparable to standard gastrectomy by the rescue surgery of recurrence, although sentinel navigation surgery in early gastric cancer did not show non-inferiority compared with standard gastrectomy in terms of 3-year disease-free survival. Next important Korean study to introduce is Papyrus study, safety of pressurized intraperitoneal aerosol chemotherapy pipette using paclitaxel in gastric cancer patients with peritoneal metastasis, which is led by Professor Hyung-woo Kim, Seoul National University Bundang Hospital. Next, let me briefly introduce the Chinese laparoscopic GI surgery study group, CIRAS. CIRAS-01, LDG versus ODG for AGC, CIRAS-02, LTG versus OTG for EGC, CIRAS-03, LDG versus ODG for advanced gastric cancer after neoadjuvant chemotherapy. CIRAS-04, laparoscopic spleen preserving lymphadenectomy for AGC, and so on. Japan trial named JLSSG0901 just showed the final result about laparoscopic gastrectomy for advanced gastric cancer. They showed that the long-term outcome met non-inferiority criteria same as Class 02 and CIRAS-01. Regarding Asian trials of laparoscopic gastrectomy for patients with neoadjuvant chemotherapy, CIRAS trial showed the feasibility of that procedure, and Japan trial showed non-inferiority, and Class 08 trial is ongoing. Another hot issue is robotic gastrectomy for gastric cancer. There were a lot of retrospective studies about feasibility of robotic gastrectomy, however mostly without proving superiority of patient outcomes. There are 3 RCTs, 1 from China and 2 from Japan. Large-scale RCT, JCOB 1907, is ongoing. There are another RCT, about perioperative outcomes between energy devices during laparoscopic gastrectomy for gastric cancer. And 15 study, a clinical trial to evaluate feasibility of the fluorescent ICG-guided tailored gastrectomy by illuminating lymph node beijing, conducted by Professor Seung-ho Kong from Seoul Regional University Hospital. Lastly, medical oncology trials in Asia. I want to introduce several practice-changing Asian trials. First, Destiny Gastric 01 trial from Japan and Korea. After Toga trial 2010, this Destiny Gastric 01 trial showed success of trastuzumab deruxtecan. It reboosted targeting HER2 in gastric cancer. Therapy with trastuzumab deruxtecan led to significant improvement in response and overall survival as compared with standard therapies among patients with HER2-positive gastric cancer. Attraction 2 trial from 3 Asian countries. Attraction 2 trial showed the long-term efficacy of nivolumab as the third or more treatment was confirmed at the 3-year follow-up, and a survival benefit of TBP with nivolumab was suggested. Lastly, Attraction 4 trial from the same 3 Asian countries. It showed that nivolumab combined with oxaliplatin-based chemotherapy significantly improved progression-free survival, but not overall survival, in Asian patients with untreated HER2-negative unresectable, advanced or recurrent gastric or G-junction cancer, and could potentially be a new first-line treatment option for these patients. Ladies and gentlemen, I'd like to summarize my talk about ongoing trials in Asia. Gastric cancer in the East shows a high incidence, early stage, low BMI, and high volume center. Surgical oncology trials in Asia were focusing on minimally invasive surgery such as laparoscopy or robotic surgery and function preserving surgery. Medical oncology trials in Asia can change practices in terms of revisiting HER2 targeting therapy and immunotherapy as the first-line therapy. Thank you for your kind attention.
We must be very thankful for this excellent presentation from Dr. Park from Korea. Unfortunately, he is not live with us, so it will be very difficult to make questions to him. But I'm sure that our moderators have other questions that are being collected online for our previous speakers that are Florian Gebauer and Jonathan Kuhls. Yogesh, please, the microphone is yours.
Yeah, thanks to all the speakers. My first question I would direct to Dr. Gebauer. Florian, you have showed a couple of studies which are targeting the new adjuvant approach followed by surgery. Now we know that in surgery, when surgery in upper GI oncology, it's not only about minimal invasive or robotics, but you have to have a certain approach, whether it may be in esophageal cancer, transhiatal or transthoracic approach. And if we consider the outcome of cross trial, especially in the adenocarcinoma histology patients. And I would like to remind of the publication from Dr. Noordman, also from the Netherlands, one of the cross contributors, who have demonstrated that compared to neoadjuvant therapy versus upfront surgery, applying the transthoracic approach, the patients had a much better outcome without the neoadjuvant chemotherapy. And to go to the gastric cancer, if we compare the data from the MRC trial and the Dutch lymphadenectomy trial from the late 90s, early 2000, then we see that the overall outcome, overall survival was almost double in numbers, 4 years and more in the only surgery treated patients compared to all the perioperative and neoadjuvant treated patients and trials that we are seeing coming up now or have been published over the last 10 years. Would you like to comment on that?
Well, I think this is an entire question complex and discusses the concept of neoadjuvant therapy itself. So I think upfront surgery is a bit outdated today. So I think, as Jonathan talked about and what I didn't show you, I think the surgery today is only one part in a multimodal concept. I think it's this, when we talk about, the problem is we cannot identify patients upfront who might benefit from the neoadjuvant therapy, either chemoradiation or chemotherapy or a immune checkpoint blocker or whatever. So this is the main problem, I think, and this is the problem of all of the studies, that is a mixture of tumors with heterogeneous response to the chemotherapy or chemoradiation therapy. And in the end, you see also this mixture in the intention to treat analysis. And of course, when you do, there are certain patients that will not profit from this kind of chemoradiation therapy, that suffer toxicity but no benefit for this. And they would profit from an upfront surgery, of course, but we cannot identify those. The problem is those patients we just published a paper. One patient has a pathologic complete response, T0 and N0. You can talk about curation of these tumors. They won't suffer from a relapse within the next 10 years. And if we have those patients, they of course benefit from a upfront chemoradiation therapy or chemotherapy. But we have to identify those kind of patients. And this is I think this is the future issue we have to address.
I have a question for Jonathan Cole, and it's something related with North American recent events. From my friends in New York, I know that at Memorial Sloan Kettering, patients suffering with esophagogastric cancer that have microsatellite instability, that is well known to be a little bit slower in aggressivity, but not responding to any kind of chemo, they go upfront to surgery anyways. Well, in this patient, there are studies dealing with immunotherapy that are very promising. And very recently, from the United States, 12 cases of intestinal type adenocarcinoma from the rectum were all identically treated. 12 is 12, but all of them had a total complete pathologic response after preoperative immunotherapy. 12 on 12. So it was a boom, and he went on the New York Times. Jonathan, do you think there is such a promising, pathway to be followed also for upper GI?
I do. So our preference right now at McGill, we used to treat, we're pretty aggressive with neoadjuvant therapy when possible. That being said, for the microsatellite unstable tumors, we tend to proceed with upfront surgery and then reserve historically reserved chemotherapy based on the pathology at the time of resection. That being said, we're beginning to routinely assess for microsatellite instability, and we're beginning to reflexively test for CPS or PD-L1 score. I think that they're interrelated. It would make, given that the data shows a high tumor mutational burden, that's what you'd expect in a microsatellite unstable tumor. And so you would expect them to have a better response to perioperative or induction immunotherapy regimens. I just don't think the data is mature in stomach yet, but I don't see why it would be different. Sloan has always kind of been a leader in basket trials, and they sort of highlighted this concept of treating tumor biology as opposed to histology. I don't see why it's going to be any different for stomach than it is for rectum, for example. So I think time will tell, but I do think it is very promising in the gastric sphere, particularly for MSI patients that don't do very well with chemotherapy historically, to get an additional therapy that might improve long-term survival.
I would like to just come here back to the point that, especially in esophageal cancer, the therapeutic options, once you have decided for a certain approach, you do neoadjuvant, chemoradiation, and then you go for surgery. What is left in case of relapse or a metastatic disease? The options are very, very few, and in esophageal cancer nowadays, there seems to be, obviously there are guidelines, but you can choose between so many options. The neoadjuvant therapy, now recently I was reading about induction chemotherapy followed by neoadjuvant chemoradio followed by surgery. So if you give everything just prior to surgery, and then there are very few options left for except for just palliative treatment in case of relapse. So my point is that we have data from like in gastric cancer from randomized controlled trials with a pretty almost a double overall survival. Yeah, these are the MRC and the Dutch trial. And why we have left the surgery only arm to take into consideration in our trials, despite not having convincing data that all patients truly benefit from a neoadjuvant or a perioperative therapy. Do you understand my point?
So I can take a first stab at that. Yeah. So it's not an easy. I mean, I don't know that I have a satisfactory answer. What I will say is that, so I'll give you our preference in McGill and what we do and sort of our failure patterns. So, we favor perioperative FLOT based on the FLOT4 trial. Prior to that, we were using a taxane-based triplet, similar results. And we do a transthoracic en bloc esophagectomy with complete lymphadenectomy. So our failures are predominantly distant, and that's my only concern when we treat adjuvantly, we don't know if we're providing any benefit, right? We assume or we look back on trials to sort of inform our decision. I will say that the one benefit I see with induction trials is that you can assess function to some extent, right? So we recently put out a paper, published it in the Annals of Surgery, I think it'll be in print shortly, showing that pathologic complete response in chemo-only patients versus chemoradiation are not the same thing. And in fact, a pathologic complete response in the chemotherapy alone arm portends a better prognosis than those patients that get chemoradiation therapy and achieve a complete response, which intuitively makes sense, but someone has to show it. So we've shown it in a multi-institution setting. So my point essentially is, can we predict survival based on pathologic metrics, right? To tailor our therapy or stop chemotherapy, for example, in patients that don't respond. So I think there are large advantages to a neoadjuvant setting, not to mention the fact that more patients will get their chemotherapy. As to why the MRC trials and the Dutch trials are showing this sort of discordant survival compared to what we're seeing now, I don't think I can answer that question.
Well, I can do that, if I may just come in. One of the quality parameters in those trials have been that surgeons from Japan, from Asian countries who were doing much more and are still doing much more gastric cancer surgery were invited to teach and educate the surgical centers in what is actually a D2 lymphadenectomy and the radicality of the surgical approach. So what I am afraid of, that we are now in this whole atmosphere of checkpoint inhibitors, neoadjuvant therapy, induction therapy, perioperative therapy, as surgeons also losing the concept of surgical standards, you know, because it seems like you do all these type of systemic therapy and radiation, and surgery can be done also as a part. But what I want to point out that despite all these therapy, I'm not against those. That was, especially as surgical oncologists, we have to rely on, and we have to educate the coming generation on surgical standards, which have been established and proven in randomized controlled trials. This is one of the reasons why the perioperative trials in gastric cancer have such poor results.
Yogesh, since we have a very large audience, I have a very short and flash question that I would ask to you, to Jan Willem, and to our panelists. And it regards the fact that since now we are establishing that pre-treating patients in a very different forms of immuno, chemo, complicated treatments, and then operating them, you know, undoubtedly in a, you know, state of nutritional immune deficit somehow. What is the difference between, you know, starting from following data coming from trials that are usually made in large institutions with high volume and where patients are by definition selected, transferring experiences and results of the trials in big data and real life? I mean, how can we rely on trials and transfer immediately that kind of indication into general practice all over the world? This is an important question because we are surgical oncology that now, right now, are diffusing a speech towards every kind of country on the planet. So what is your opinion about that not secondary point? All of you.
Sure, I can start. So I think it's an excellent point. I think we can simplify the my understanding at least, we can simplify a little bit the management of esophageal or gastric cancer. We have local regional treatments, and we have treatments aimed at preventing systemic recurrence. I think nothing is going to replace the surgical principles, at least in the near future, of esophagogastric surgery. That being extensive lymphadenectomy. We do a D2 routinely. And then we do an en bloc resection in the chest. And that is your local regional control, really. If the addition of radiation is necessary, that is, you know, that depends on your training and the institution you work at. But I think you have to be honest with yourself, and are you able to achieve the quality metrics of surgery that are going to have a significant impact on both local, regional, and distant control? And that is, can you achieve an R0 resection? Can you achieve an adequate lymph node yield? And are your survival outcomes appropriate for this pathology, given that it's quite a high risk surgery? So I think all this information on perioperative therapies is sort of takes the high quality surgery as a given, which may or may not be the case at every center. But I think those quality metrics have to be met. And I think you have to be honest with yourself, your surgeons and your oncologists and your radiation oncologists to come up with a strategy that is going to give you as high quality an outcome as you can get, both in the short and long term.
If I can comment on that, I think it's completely true that it's about the quality, about the quality of surgery, and that's from the one of the famous Dutch cross trial you mentioned earlier. One of the comments I heard a lot in England is that the quality was perhaps not good enough. You're comparing transhiatal esophageectomies with chemoradiotherapy and things like that, and I think truly common that the quality of surgery, if you look at the numbers about lymph node yield, local regional control, was not that good enough in cross, mainly part due to all these transhiatal esophageectomies. But I think that cross showed improvement. Why did it show that? Because you got local regional control with your chemoradiotherapy. So that's what we said. It can help that if the surgery is not good enough, then perhaps the local regional control will be achieved by adding of the neoadjuvant chemoradiotherapy. So I think that's something we in Holland, in the Netherlands, we completely switched to transthoracic approaches. So the lymph node yield went up. So I think the quality of surgery is also completely different now, much improved since the cross trial was done. And now, yeah, I think it's still what one of the other speakers also said. It's much more important, the multimodality. If you need to have the highest standard of surgical approaches with, I think, the multimodality treatment. I really like the concept of the induction therapy. You have to have your personalized treatment. Every biology of a tumor is different. If you have induction treatment before you neoadjuvant, I really like that concept. So I think that will be the future. Together, like Yogi said, it must be done with the best surgery, with high standards to get the best results.
I believe to apply the results from the randomized controlled trials, and so many are going on worldwide, to a broader patient cohort, also the surgical standard must be taken into consideration in the trial design. You know, you just cannot say you have to resect and that's left to the surgeon's choice, whether he's doing a transhiatal or transthoracic, or is he doing a D2 lymphadenectomy or not, or the extent of lymph node dissection, esophageal surgery. These parameters need also to be defined and taken into the trial design to have true clear data. Otherwise, we won't come out of this ongoing debate which surgical approach is better and whether the neoadjuvant or perioperative treatment do truly benefit. This is my personal point of view, what I conclude from the available data.
I agree.
Please.
I agree fully that the type of operation should be standardized. But as Domenico said, what we just learned from rectal cancer, and maybe I'm the devil advocate, I think the surgery will become less important in the future within the next years, as we saw after the induction of immune checkpoint blockade in rectal cancer. And I think maybe not in esophageal cancer, because we do not have microsatellite instable esophageal cancer, but the immune checkpoints will change the entire oncological setup radically, I think. And we will see from these active surveillance studies, maybe this is a little bit old-fashioned therapy protocols with the classical chemoradiation therapy there. But once we add immune checkpoint and maybe novel agents, I think the operation will only become a smaller part in the entire setup. And I think upfront surgery studies will not be conducted in the future. This is my personal opinion, because I don't think there is reason for that to do.
You are probably right, but for the sake of the fact that you are surgical oncologists, I would like to express my opinion on that. And I would not say that surgery will be less important. I think we will be an important leg of the table that will support the entire therapeutic strategy. But what will become very different in the next future is that, as we are doing with the identification of different kind of patients that are sensible to different kind of treatments, towards something that is precision tailored treatment plan, we are going probably to have precision surgery in the light of a less aggressive treatment in organ preservation. So we will probably approach every single patient differently according to the kind of treatment that he received and the type of response. I'm imagining that D2, that is do the same for everybody, somebody will benefit, will be different. Do the less you can do, provided that it will be efficient for that kind of patient. So this is something that came out with Umberto Veronesi and breast preservation, 30 years ago, and we are starting to think about the same way in upper GI. That was the last in class, because that these cancers have been not so encouraging about their results in the last 25 years. But the time is short, and I think that we still have 100 people listening. I am very, very grateful for that. I would stick to the plan and leave to Jan Willem van den Berg a summary and the conclusion for this meeting.
Yeah, well, thank you all. Of course, it's great to have you all. It's like Professor Diogo said when we started, it's great to have an event like this with young oncological surgeons, and that we see all these topics over the world. We started with Dr. Gebauer, and I think it was a great overview of showing what we do in Europe, with all these different neoadjuvant regimens we are comparing, but also about, we didn't discuss that today, about all these complete remission studies. We are here now. We are in Holland. We are not participating in that, but the SANO 1, the SANO 2, there are some limitations in my opinion about that, but I think it's a great strategy also that it's not only about I think the surgeon, like the professor said, is just very, very important, but it's also all the other modalities, and I think it was a really nice overview you showed us. And after that, Jonathan, also amazing discussion, amazing presentation. Thank you very much for everything you told us today. For me, it was a real eye-opening to see. I think if I listen to you, then it's not only the surgical approach has to be optimal, but after, like the induction therapy I said before, starting your chemoradiotherapy or your chemotherapy, so you have a double induction with your neoadjuvant treatment. It could be the new standard, that we first give induction therapy to see, and after that see if there's any remission of disease, and then they have the different parts. So I think that's a really nice main topic of what we see as a future approach for a standard. And also Dr. Park, of course, Professor Park, unfortunately wasn't able to join, but it was amazing to hear all these, this class. I've myself been in Seoul, and it's amazing what they do, the amount of people or patients they have, but also the amount of research, mainly on the surgical approaches, all the class 1 and 8, but luckily they also showed that they have a lot of ongoing on the multi-modality treatment. So I think summarizing all three presentations are great. I think it's a great first webinar held by this RPGI group, and I hope it will be the start of a lot of more webinars, and also hope to see you in the ESSO conference, of course, in October. And we also are planning to have some hands-on course next year that will be, so hope you can stay in touch by the ESSO course. And I'll perhaps some final remarks from Professor Hugo before we can end the session.
Yes, thank you very much for this excellent summary. I am the first to be thankful to Jonathan Kuhls, to Florian Gebauer, to Yogesh Vashist, Jan Willem van der Berg, Dr. Park from Korea, and all of you that for 1.5 hours from all over the world have been listening. Thanks again. It was a pleasure, and it's encouraging for me as the president of this interesting and great society. Thank you very much. Have a good night.
Good night. Thank you to the speakers. Bye, Goa.